So welcome everyone. I want to thank you if you're here in person on the Zoom membership. I want to thank you for getting on tonight. I'm excited to be back after the summer break, and tonight we're really excited because we have Dr. Claudia Tamas, who is our speaker tonight. She's going to be outlining some of the great other things that you can do besides medications to actually help you with lifestyle changes that can improve your bone density scores. And certainly we're excited to hear about that. I'd like to tell you a little bit about Claudia, Dr. Tamas. She is a doctor of physical therapy, but she's got a lot of other hats that she wears as well. Um, and so she's also a registered nurse. She's about to become a nurse practitioner as well. She's a strength and conditioning coach specialist and was certified with special certification for that. Um, she's also a licensed ONERO provider. And we're pretty familiar with that in this group, Claudia. And she's actually the first clinician that Dr. Belinda Beck brought into this program in the United States. So how exciting is that? Um, she is also the director of the Women's Health and Natural Medicine and Rehabilitation that's in Somerset, New Jersey. She was raised in Romania. She received training initially as a teacher, and then she moved to the US and furthered her education and became a registered nurse and got her bachelor's in registered nursing. She then got a clinical doctorate in physical therapy, went on to keep continuing. I think she really likes education. And after almost a decade in private practice, she went back to get a nurse practitioner degree, and as I said, in adult gerontology. She's passionate about educating, about supporting her patients, and pursuing their physical potential at any age. She believes strongly in our ability to not get become feeble, to actually become strong and live independently and strongly and fitfully our entire life. And so I'm real excited to present her tonight. And a quote that I heard her say that I thought was really exciting was that loading the body with weight bearing is probably the most important factor when looking at the reality of our bone health. Tonight, she's going to talk about that as well as many other factors. Anyway, thank you so much, Claudia. We're excited to have you tonight.
Shelley, thank you so much. And it's really an honor to be here and to share some of the strategies that I've learned through my lifetime education, as you can see, and also in clinical practice with my patients. I'm going to go ahead and share my screen.
Great.
So Shelley, just let me know if you're able to see it.
Yes, we can see it. Perfect.
Okay.
That's perfect.
So I was telling Shelley initially that I had so much content. I got really excited. I have a lot of content that I like to share, and I had to cut some of it out. I also know that your audience is very educated, and some of the strategies that I'll be sharing you already know. So I hope I can bring some depth to that. And maybe I will be introducing something new. Who knows?
I'm sure.
Yeah. I will say that I had conversations with patients over a decade in clinical practice, and more intensely over the last 4 years since we've been running ONERO on our practice. And this comes up a lot. actually, I want to lower the, okay, here we go. This comes up a lot. Women will say, I received the diagnosis of osteoporosis and I simply couldn't breathe. I didn't know what to do. I was afraid I was simply going to crumble. Um, and walking alongside women and some men, not many, but we do have men in our practice as well, to bring them forth from fear to confidence has been a mission for me. There is nothing more stifling to human potential than fear. Um, and there are two areas in which I educate my patients to support them. One is understanding that we have an incredible God-given potential that is ready to burst out if we create the right environment for it. We are not weak and we are not going to crumble. And it just has been an incredible honor to create that environment for my patients and to watch that potential emerge on their journey from fear to confidence. The second area in which I educate them is the nature of this condition. I found this concept, disease as opposed to intelligent response, in the writings of Dr. Susan Brown. She wrote about this 40 years ago, and she's an anthropologist, so a lot of her writings resonate with me because I come from a different culture, and I did experience a different way of living, which gave me a perspective about our human potential and what our bodies are capable of doing. So what do I mean by disease or response? This can be quite an empowering concept. If we're thinking of osteoporosis as a response of our body to the environment, for example, we know that something that everyone knows is that muscles and bones are extremely sensitive to mechanical stress or to loading. How do we know that? Well, when the astronauts went in space, what happened? In microgravity, these were middle-aged men, and they got osteoporosis. This is how sensitive our muscles and bones are to loading. And this is how adaptive our body is to the environment. So we remove loading, the body removes muscle and bone. And the beauty of this is that we can also do the opposite, and we can get the opposite response. Most people would be surprised how little it takes when we are looking at creating a big impact. And I like this representation. This is from a book called Atomic Habits from James Clear. And I love that. It's super eye-opening when we're looking at applying 1% of change towards a goal every single day will bring us to almost a 40% improvement by the end of that year. And this is how we work in ONERO too. The increments that we go by with waist strengthening is almost barely noticeable. But at the end of that year, the progress that we achieve is enormous. In the same way, if we're looking at the line going downward, decline will happen without us if we're not paying attention. So in a year, if we're just going about our routine without paying attention, without making any change, we will not stay the same. We will actually decline. And this is a very important concept to understand, that our routines, our daily routines are incredibly powerful. I always encourage my patients to not just go through the motions, that every single thing that they do day in and day out matter and can count toward that upward line or towards the downward line. This was quite shocking, and I know that this audience is very active, so I thought this picture was funny, but I was shocked by this statistic that about 65 to 80% of people over 60 spend their waking hours in low energy activities. And I actually would say that this applies to almost all ages. We are living in the West, we're comfortable. We are sitting in the car, we are sitting at the table, we are sitting at work, and then we're sitting some more at home after work, watching TV or performing other low energy activities. And so when we're looking at disease or intelligent response, we can see that our body is just going to simply adapt to behaviors like this by getting weaker. We know that saying, if we don't use it, we lose it. And that simply applies to how our bones and how our muscles are preserved or wasted. So what is this response? If we're looking at the bone, if you're looking at the left slide, we're seeing healthy bone. So our bones are normally a little porous. And on the right side, we're seeing the response to lack of loading, for example, but there are also other factors. And we're going to go ahead today and unpack all the different factors. If we're taking just mechanical stress, for example, for someone who is sedentary or somebody who doesn't load their body at all, we live in a world in which we're not lifting, carrying, we're not pushing, pulling. All of these activities have disappeared from this culture. I grew up in a different culture. I grew up in Romania. We were in a very small community, isolated, far, far away from progress. We didn't even have roads, and we carried everything on our backs. This was a community in which heavy physical work was performed by men and by women, working side by side, and I was witness to this. Osteoporosis and fractures were just simply not existent in that community. This experience gave me a different perspective when I moved to the States, and I saw what an incredible problem we have here with fracture rate and osteoporosis. And of course, it made me dig a little bit deeper to understand what has happened, to see this big difference in our lifestyle. The Surgeon General agrees with us. In 2004, they put this statement forth, saying that they were putting a great effort in preventing and treating osteoporosis. And I like to put this pyramid here because the standard of care, and I'm learning now through, as I'm pursuing a nurse practitioner degree, is to approach this condition with lifestyle changes first, because we do understand that this is a response to lifestyle. What are those lifestyle changes? Well, they mentioned nutrition, physical activity, and fall prevention as some of the major factors. However, if we are going into any provider's office, we will see that that's not the case at all. Or if it is, the recommendations are quite vague. And usually we go straight to pharmacotherapy, which should be employed after we worked on lifestyle changes for a while. We investigated the existence of any other secondary factors, which I will bring up, and we'll look at them in a little later into the slides. And then, and only then, if this failed, then we can support the patient with pharmaceuticals. And unfortunately, although this was put out there 20 years ago, we haven't seen anything changes in terms of the statistics. And we know why, because there's no training in giving specific recommendations in lifestyle. And so here we are, have a meeting here and really wanting to dig in to see what exactly are these recommendations, because I know that most of my patients and most patients that are diagnosed with osteoporosis are not satisfied with simply being prescribed the medication. A lot of them are educated, and they do understand that lifestyle plays an enormous role in this condition and in its reversal. I put this here. You probably know about these statistics. They are still very, very concerning. And this is why we're having this conversation. 300,000 hip fractures a year. That hasn't changed in 20 years, despite this initiative. And one statistics that I came across that was quite shocking is the fact that men actually account for nearly 1/3 of all hip fractures, and unfortunately have way poorer outcomes when it comes to fracture. And this was something that I was interested to investigate, and I'll try to unpack later through my slides as to why this is the case. So what are some of the concerns with osteoporosis? Of course, fracture is a concern. But for me as a clinician, I'm always concerned with the entire health of my patient. I'm concerned with their longevity. I'm concerned with their quality of life. And I'm concerned with their ability to remain independent, to live in their homes. And like my grandmother said, she said, I want to live and I want to die in my boots. I don't have time to lay down and die. She was just so active. She was so strong. And that was her goal, to be strong and independent for the rest of her life. And that's my goal for my patients. So when we're looking at this big picture, the concern is that we have an impact on the entire body. And this may be probably the most important slide in my presentation. And I would like to take the time and unpack this a little bit. So if we're looking at the picture on the left, this is where we see appropriate optimal posture, good alignment. And then we're seeing on the second lady here, something has changed, something has shifted. The head has shifted forward. We have more pressure into this area. This is called the thoracic spine. And this anomaly is called a kyphotic curvature. The kyphotic curvature collapses the spine forward, meaning that it bends it forward. And in front of the spine, we have, if you look at the skeleton here, we have the ribs. Underneath the ribs, we have our respiratory system, which is the lungs. This is a big concern because as the rib cage collapses on top of our lungs, our vital capacity, which is our ability to expand our lungs, decreases. This is a big deal because loss of vital capacity is associated with high mortality and morbidity. Why does that matter? Well, this is why we see these poor recovery rates when patients fracture. Actually, the poor recovery and the loss of life is a consequence of respiratory failure or respiratory infection. After these fractures, people don't die from the fracture. They die because they have become physiologically bankrupt because of all of these changes that have occurred in other systems of their body due to this collapse of the skeletal architecture. If we're looking at the lady on the right, we're seeing that now these changes are even more pronounced. The head has shifted forward even more, and the curvature in the thoracic spine has increased. This has, if you were looking at the third representation here, shifted the ribs right on top of the pelvis here, closed even more the respiratory system. Of course, the heart is there too. So we're going to have cardiovascular changes. The digestive system is pushed forward. So this person didn't gain weight. This is their digestive system that doesn't have room under the rib cage any longer and is pushed forward. Of course, this alters the activity in the gastrointestinal system. It's going to alter the person's ability to absorb nutrients, which is even a greater concern with osteoporosis. So we find ourselves in a vicious cycle here. And then there are pressures going downward as well into the bowel and bladder. And we're seeing concerns with incontinence. So you can see how, oh, and I didn't even bring up the nervous system. And the nervous system lives in within our vertebral column and in our skull. So that's the central nervous system. As we're seeing changes in the spine, and the spine is collapsing forward, we see increased tension into the central nervous system, chronic pain, and even cognitive impairment due to the traction into the nervous system. So these changes are probably some of the most important thing and most preventable that we can immediately start working on and applying that 1% that I was showing you in that initial slide. If you already see changes occurring, or if you're not sure, this is so easy to do, to find a physical therapist and ask them to assess your posture. It takes 10-15 minutes and they can give you some exercises. So if you're already showing some signs that the head has shifted forward and these changes are occurring, this is probably one of the best things to do to start doing some work in reversing those changes. If you are here already, this is still not too late. We had patients coming in working with us in ONERO, and we're measuring this. I will show you the technology that I use, but we don't really have to be fancy with this. Any physical therapist can do this. And even at this stage, we can see improvements in bringing that person more vertical, working with opening that vital capacity, doing respiratory and diaphragm exercising, because I am concerned that if my patient does end up fracturing, I want them to be able to recover. Here is Dr. Renee Calais making the same statement, agreeing with this, that thoracic flexion, which is the curvature in our thoracic spine, right? The more of it we have, the less lung capacity we have. And you understand how that happens mechanically. Lung capacity can be decreased as much as 30%. And then, of course, the third concern is fracture recovery. I am so preoccupied with the fact that we have such poor recovery numbers. We live in the West with this incredible medical system. We have so much of our fingertips, and yet our 1/3 of people that fractured their hip die in the first year. Well, we have to do a better job than that. And that has to start with us understanding why that is happening. That's why it's happening, because we have an enormous compromise in the cardiovascular and respiratory system to begin with. So by the time that patient fractures, they have no more resources to recover or bounce back from that fracture. And I can't say this enough. This is one of the most preventable things that we can start working on early. If you're noticing on a friend, or if you're noticing on yourself, we can start the work, and this will be incredibly helpful, not only in preventing these changes, but also recovery from any health event. So these are just some pictures on how these fractures look like. In the spine, we have compression fractures. This area in the hip, this is the hip. This is the most vulnerable area where we see fractures in the femoral neck. Have these pictures in mind, because later I'll talk about why some of the exercises that were recommended are so critical, particularly to strengthen those two areas that are so vulnerable for fracture. I saw this concept again in Dr. Brown's book, and it resonated with me deeply because I know that lifestyle plays such a huge role. And what she did in this picture on the right, she dumped all these lifestyle factors on top of this camel. That's your bone health, right? So when we're assessing a patient, we have to go hunting. Which are these factors that apply to them, because every person has their unique journey. I did something different with them. I like to organize things because it makes it easier for me to approach a treatment plan. So I took those factors and I placed them into 3 categories. And this is what we're going to do for the rest of the presentation. We're going to try to unpack each category of these factors that affect our bone health. So the one category, mechanical stress, right? So we're mechanical stress, we're talking about loading the bone. This refers to exercise. And mechanical stress, we're going to talk about emotional factors. We know that our emotions have physical consequences, and cortisol is just one of those consequences. Chemical and metabolic factors, we're going to unpack that a little bit. Each of these is worth probably a lecture on their own, but they are definitely worth mentioning. And it's I like to get organized on these categories because people then understand a little bit better that this doesn't have to be overwhelming, that we can get organized and see which one applies to us, and start the work somewhere. So let's talk about mechanical factors. Mechanical stress refers to loading on the bone. I can't say this enough. I love this. In 2017, this was published by Cambridge University. This was an archaeological site. They found this bone. This is an arm bone, a humerus bone belonging to a female that lived 7,000 years ago. And what they did is they compared the bone density from this old bone to a young 25 female athlete in the rowing team, the rowing Olympic team. And it was incredible what they saw. This bone was actually 30% stronger than the bone of this athlete. So of course the question was, well, how are these people living to get such strong bones? And so the archaeologists answered that question. So they say, well, in these communities, these women were lifting heavy. They were pushing, pulling, carrying loads. And that sounded a lot like what we were doing in the community that I was living in. Very, very similar type of activities. Here on the left is just an activity that we used to do in the summer. This is called the Romanian haystack. And I didn't have a picture of my mom, but me and her used to do this every summer. I would be up there on the haystack and my mom would be lifting, and maybe that is, I don't know, 20, 30 kilos, maybe 60 pounds, hundreds of times overhead until we finish this haystack all the way from the bottom to the top. And this is almost inconceivable when we're telling patients that, oh, we're going to lift 60 pounds overhead. And yet, this is possible, talking about human potential. So because of my background, I know what is possible. And a lot of my patients achieve this goal of insane strength. We do it wisely and we do it progressively, but we achieve it. On the right side, we see something else in the hip. We see this movement. It's a deep squat that some of the cultures, including my culture, were utilizing. And when we're looking at studies, you know, when I showed you that picture of the femoral neck where it fractures, there's a vulnerable area right there. Well, the only way we can strengthen that area is if we load the hip in a deep flex position, which is a deep squat. So in many of these cultures, even though women get low bone density, they simply don't fracture because the resilience in the femoral neck, the geometry of the collagen fibers are fracture protective. Here are some pictures from the community I grew up in. So some of these ladies, we always carried stuff on our backs, heavy loads, and we We didn't know that osteoporosis even existed. And now this is almost 50 years later, and things have changed there too. And we have cars and we have comfort. And my mom is telling me that people in the younger generations, she continues to work in the same way, but she says that people in the younger generations now have that condition. So aside from my experience that I'm sharing with you, is there any research that supports what I'm saying? Because of course, as a clinician, I cannot just go with my experience. I have to have some research to back this up. And yes, there is. I dug it out. There is one study from 1996. It's a bit old, but nevertheless, it's talking about how in this community, in Gambia, women don't fracture their hips. And what they did, they took this was a large study. They look at, they compare women in this community with women in England. And they compare their bone density. And it was shocking what they found. Was that the women in Gambia actually had way lower bone densities than the women in England, and yet their fracture rate was almost zero. And so again, why is this happening? There's same activities that are fracture protective. Working with flexed hips, deep squat, pushing, pulling, lifting, carrying. These activities constantly come back, and loading the body through these very specific movements. In the middle here, we have another study, and this is quite recent, and I love to present it. There are many others like it. I particularly love this one. It looks at the musculature around the spine that supports the spinal architecture. We call those muscles multifidi. And so what the researchers did, they look at the fracture risk, and the people with the same bone density, who fractured and who didn't. So at the same bone density, people that had a strong, healthy muscle in the multifidi muscle, they didn't fracture. And people that had fatty infiltration simply refers to a deconditioned muscle, a weak muscle, had high rates of fracture, even though their bone density was exactly the same. This is so important for me and for the work that I do, because I strongly believe, based on this data and on the experience, on my previous experience, what I grew up and what I'm seeing with my patients, that muscle quality is the #1 fracture protective factor when we're looking at osteoporosis. Here's another study here on the right. They looked at calf muscle density. And once again, they found that is a major factor associated with low fracture risk, independent of fracs and bone density. So it keeps coming back that we need to work on preserving musculature and muscle quality. So what has happened with what happened, what adaptation has occurred here? So on the left, we see the lady with the load, right? She's carrying the baby, she's carrying the load on her head. And I couldn't find a picture in my community, but this looks a lot like how we lived. And now we're living in the West, where we don't need to do stuff like this. We have a carriage for the baby, and the loads are carried in cars, and that's not a lifestyle anymore here. So then the body responds of creating different structures, and then the response is weaker bones and weaker muscles. So then you may ask, well, we can go back to living this way. So what is the solution? The solution is to come up with the same movements and the same loads that we can offer patients in the clinic under supervised conditions. We know that these movements work. We've seen these cultures, we've seen the research. We have to bring patients in, and we have to load their bodies in such a way that we will create a different adaptation to mechanical stress, in which we will see stronger bones and stronger muscles. So we unpacked the mechanical factors that have to do with exercise. Let's touch upon metabolic factors. Here we have pharmaceuticals. I won't spend a lot of time here. This is a big list of drugs that we know that cause osteoporosis or influence the bone in a negative manner. Some of the most common ones, proton pump inhibitors, which are your antacids, and these are some of the most common ones. And SSRIs, anti-epileptics, the steroids will do that. Why is this important to know? Some of these medications, patients cannot come off them. These are lifetime. But for example, the anti-acid medications, well, we want to encourage patients to work with a good functional medicine doctor and come off those to optimize their digestion. These are big factors when we're looking at bone metabolism. Then, of course, in the metabolic category enters the lifestyle, diets that are suboptimal, anti-nutrients. What are these? Alcohol, smoking, toxicity. We know we're exposed to different toxins, and this could be a lecture on its own. Other disease or comorbidities, and we know that the hormone factor is big. We see some of the greatest bone loss around menopause. We lose about 15 to 20% of bone right there. So we know that estrogen, progesterone plays a role when we're looking at metabolic factors. Other diseases can be important here. I'm just bringing these up because we want to create a comprehensive view and understanding in various areas in which we can see problems here with bone metabolism. So some of the most common one is thyroid disease, right? That has to be under control. If you have that issue, you want to make sure that the thyroid is checked, is under control, that you're receiving the supplementation that you need. Diabetes is a big one, and metabolic syndrome. These all influence bone metabolism secondary. Okay, we know immobilization, renal disease, and bone marrow disorders. Going back to digestion, well, this is the gateway for the nutrients to your bones. So if there is a concern there, I usually have patients work with a functional medicine doctor. There's some testing that needs to be done to ensure that digestion is appropriate. There are any signs of poor absorptions. There are micronutrient tests that can be run. And then there are certain procedures that compromise absorption of nutrients, such as post-gastrectomy, meaning there's no stomach, or hepatobiliary disease, gallbladder, right, removal. There's concern there with absorption of nutrients. So you have to work with somebody who will help you supplement in such a manner that you can have better absorption, particularly of proteins and fats. Going over emotional factors, here we're specifically talking about stress and bone health. Maybe you've been exposed to this to understand we have two parts of our autonomic system. On the left, you see the fight or flight situation where we're very, very stressed. Something is happening and there's an acute stress response occurring. And on the right side, we call this rest and digest. And for 90% or maybe 95% of our time, we should be in the rest and digest phase. Unfortunately, when we have chronic unmitigated stress, this fight or flight can occur over long periods of times. And then we're concerned with extra cortisol. This is a stress hormone, and this is a very simplified diagram of how cortisol affects bone metabolism. So our emotions create a physiological response of our body in our body by production of cortisol. Cortisol will reduce bone formation. It acts on osteoblasts, which are your bone building cells. It does increase osteoclastic activity and excretion of calcium in the urine, influences vitamin D synthesis. So how incredible, right? Our emotions can create such intense responses in bone metabolism. So if this is the factor that is concerning you, then you want to work in that category. And we're going to talk about some strategies that we can employ in all of these categories, risk factor categories. This is a study coming from the Women's Health Initiative. So they looked at this, concluded that psychosocial stress is linked to increased fracture risk in older adults. So this is not a joke. Long-term unmitigated stress has to be addressed because it is a problem, even if you're doing everything else right. Okay, so let's talk about lifestyle strategies. So what can we do about these things? Now we know what they are. Let's see what are some things that we can employ. So I like to bring exercise to the table first. We know that exercise has whole body effects, both positive when we do it and negative when we don't do it. World Health Organization puts this out. Well, lack of exercise is the enemy, right? We have all of these chronic diseases, and the root is inactivity. Root cause. But I found something even more interesting here, that if we don't specifically exercise our muscles, something really significant happens. Over a lifetime, bone mass decreases by 47% in women, 30% in men. And back muscle strength, do you remember those back muscles that I was telling you they were fracture protective? The same back muscles that keep us upright so we can maintain vital capacity and expand our lungs. Well, those muscles, they go down by 50% if we don't exercise them, and by 64% of men down. Do you remember when I mentioned that statistic that men fare way poorly after hip fractures? Here's your answer. Right? They have less physiological resources because they do lose more muscle if they don't exercise. So what kind of exercise works? Well, I would say that I want everyone to do ONERO and lift weights. This has to be supervised. If you're not close to a program like this, I would highly recommend that you go into a physical therapy practice and you start working on strengthening postural muscles and doing some strength training with weights. So strength training with weights improve bone muscle density, quality and geometry, and I'm gonna bring that up when we talk about the Liftmor study a little bit more. Improve muscle strength, reduces fall risk, improve postures, and prevents pelvic organ prolapse. This is so important if you remember that diagram with the postural changes, right? The more our body collapses forward, the more pressure we have into the bowel and bladder, and the more concern we have with incontinence. Why do I keep bringing that up? Because incontinence is one of the #1 factors why people go into nursing home. So to me, that's incredibly important. I need to prevent that in my patient right away. So if I see any signs of that, I need to address it immediately in my program because I am interested in preserving their independence. Now, so here's the Liftmor study. So you all familiar with ONERO and the Liftmor trial. It really just brought a lot of joy to me. I always exercise my patients with weights. You know my background. I knew that we have to work heavy to maintain our muscle. And here comes the Bone Clinic, published this in 2018, and this resonated with me so deeply. I reached out to Dr. Beck and brought the program to the States. We were the first ones to bring ONERO here. The title sounds scary: high intensity resistance and impact training in postmenopausal women, but really what it is, this is a very controlled movement. These exercises are not done fast. We do them slow. We build the patient's postural architecture first. We teach them core strategies. We teach them intra-abdominal pressure, and then we start loading them so slowly. And the way we load them in our clinic, I follow that diagram. One very small increments, and then we waiting for the body to respond, and we increase again. It's just been incredibly just brought me so much joy over the last 4 years to watch my patients emerging strong and confident. There is something incredible about physical strength. It makes us more confident. It makes us stand taller. It makes us have a whole different mindset about life. So that's ONERO and high intensity training. I have the same diagram here. We're talking about the same musculature, the back extensors, right? We were looking at those studies earlier that showed fracture protection independent of bone density. And when in the Liftmor study, they actually measured the strength of the back extensors, and this improved in a tremendous way. So this is another reason why I love this program. And of course, the movements. What are the movements? Well, the movements are exactly like those movements in those communities, mimicking pushing, pulling, squatting, lifting, and so on. So it made complete sense to me to bring this to my patients. Here they are, so beautiful. We see this multifidi. Do you see how they support the spinal architecture? So we're really after this musculature. If you can do ONERO, work with a physical therapist and have them strengthen your back extensors and your hip extensors, because we're going to talk about that next, because that's how we're going to upright these postures. Okay, what are some of the concerns and why people are scared to work with weights? The concerns are valid. And fear of injury, right? The patient's frail. It has to be done under supervision. I can't overstate that. If you see this lady on the left, she's given 2 pounds and she's exercising with poor posture. Well, that's not going to help her. That weight is not significant enough to make any change for her. And she should be way more upright performing that. And so a lot of patients work below the threshold and they don't get results. Muscles and bone, they require a higher strain, and these exercises have to be done under supervision. In our clinic for our patients, we spend almost a couple of months, sometimes a little bit less, just uprighting the patient, working on safety principles, breathing, pelvic floor, and core before we even load them. So let's touch on strategies for stress. I thought this was funny. I heard the lavender reduces stress. So we have a strategy here. But here are some things that I want to mention in terms of modalities that we can use. I am certain you are familiar with all of them. My favorite one is exercise. It does work. Exercise, prayer, meditation, social connection, nutrition, all of these factors, so important for stress. Most of this is not news for you. I'm sure you're familiar with it. And here's my favorite modality, biofeedback therapy. Biofeedback therapy is an excellent modality. And it's so eye-opening for patients. We do it in our clinic. You place sensors on the patient. There's various areas of tension. And then they can see on the screen their stress response. It's so fascinating and so eye-opening. So we're recording blood pressure, heart rate, muscle tension, and they're all represented on the screen. And then the patient is given a stressor. Like something stressful. They are asked to tell a story that's really stressful to them, and they see all of these biomarkers moving. And then the clinician starts training the patient on more appropriate stress response. It's really incredible work. So if you have something close to you and you need a little better handle on how to address your stress physiologically, this is a wonderful therapy. Let's touch upon nutrition. We talked earlier about digestion and absorption. Without optimization of digestion and absorption, we're not going to have nutrients that go to the bone. So that is just as simple as that. Work with a functional medicine doctor if you have concerns. We need to take adequate bone building nutrients. What are they? For my patients in our program, as a general rule, we discuss protein intake. The research shows that about 1.5 grams per kilogram body weight will support a program in which the patient is weightlifting and wants to build muscle and bone. And this is what we're shooting for in our ONERO program. Certainly reduction in any anti-nutrients for the bone, like alcohol consumption, extra caffeine, smoking, and such, and encouraging intake of fibrous vegetation, 6 servings a day. The more varied, the better. What does that mean? We see in some of the studies that it's not necessarily the amount of fibrovegetation, but the variety. We have done some challenges in our practice where we had patients challenged to go in the produce section of the grocery store and pick 18 to 20 vegetables. We brought them home, we chopped them, we mixed them up. We had a big mountain of these 20 vegetables, and then we put them on mason jars. And this was something they ate a lunch every day. So then every day at lunch, they were eating 20 different vegetables. It was incredible. We know that in Aboriginal communities where people eat a large variety of vegetation, particularly fibrous vegetation, we see a large variety in their gut ecosystem, better immune system, better health, and lack of chronic disease. So this is something fun to do for a challenge. Go for it if you want. It's not super hard. It takes you just about an hour to prep. Here's our general recommendation for your plate. In our practice, 50% of that plate should be filled with those fibrous vegetables. The more varied, the better. We like the proteins. We need that to build bone and muscle. And then we can use complex carbohydrates. And as you can see there, we're adding more salads and greens to that plate on the right side. So what are some of the assessments that are important to assess fracture risk? Because that is this is all about. I like this study. This is from 2009. And once again, I like to keep bringing this up because I think it's so important to know that we don't want to hang our hats on the DEXA alone. I think DEXA is important. I actually think DEXA is very important, or if you're doing REMS or whichever test you are doing. I think the problem with it is that they are not preventative anymore because we're doing them too late. I've been lobbying to start these tests at least around 40 years old because then we can make them into a preventative test. Right now, they are just diagnostic. If you got a DEXA, you got a diagnosis. In order to be a prevention test, it has to be done earlier. So with the first signs of deficits, we can immediately start turning that around. But unfortunately, it's not done like that. So that is why I'm so upset with it. But anyway, this study looks at fracture risk and fracture probability across ages. So if you see here, this representation looks at, this is the bone density on the bottom, which is a T-score. You know, that's how they do it. So we're seeing, so on the vertical line, we have age, right? So 50, 60, 70, 80. And so what this is showing here is that the same bone density, let's say -3, an 80-year-old has almost 20 times higher risk for fracture than a 50-year-old. Well, why, if the bone density is the same? What is different? Well, what is different is that they lost a lot of muscle. They are frail now, and they are more likely to fall. Well, muscle strength, muscle quality has a lot to do with balance, right? So super eye-opening, right? If the bone density is the same, why is there an increase by 20 times in fracture risk? That is an important question for me to ask, because if I want to change that for my 80-year-old patient, that's what I'm going to change. I'm going to change their muscle strength, muscle quality, and balance. And this is what we're working on with my 80-year-old patients in the clinic. So this research is supportive of it, right? Once again, we're looking at the fact that muscle is protective against fractures, right? So incredibly important to preserve it. Here it is, once again. And so those are the spinal muscles. Now I want to talk a little bit about other muscle groups and what specifically what we're seeing in women and menopause. I don't have studies in men, but I think that it's pretty similar in men too. Here on the left, we have the hip. This is a human hip. Here, where my pointer is this vulnerable area where we fracture the femoral neck. It's just showing you how this occurs. And then here on the right side, it's a representation. Now we're looking from the back here on where some of the hip musculature, which are the deep external rotator musculature, inserts right in that area. Now, what we're seeing in some of the studies that I saw in women post-menopause is weakening of this musculature here that inserts in the femoral neck. And that is a bad thing, because as soon as we have decreased pull or decreased load in that femoral neck, we are going to have loss of bone, right? Pull of the muscle increases bone density. Weaker muscles decreases bone density. So important to understand that. So what should we do about it? Oh, here's a little bit more data on that, right? So we see decreased muscle mass and increased fat infiltration, particularly in the glutes, right? The deeper musculature, the glute maximus and medius, because they have a really high receptor affinity for estrogen. So what do we have to do? Well, we have to emphasize resistance training. We have to awaken these muscles. We have to bring them back. We have to put that nutrition back in. We have to get those proteins. We need to recover this muscle mass and muscle quality back to the body. What is the exercise? One day you all know. Well, the squat exercise will access the glutes, will access the deep hip musculature. And I showed you before, this is what we've been talking about the entire time. That's what these cultures do. They don't fracture, even though they have low bone density. They squat deep, they perform activities with the hip bent. And sadly, these are the very activities that in this culture, nobody does and avoids with exercise. I have patients in our clinic in their 70s. They've never performed a squat. Super, super important. We see this in research. We see this anthropologically and historically. This is so important. Not to mention the glutes are critical for gait, posture, pelvic stability, and so always linked to low back pain and hip instability. How else do we test muscle strength? These are fun to do. This is called on the left, the 5 times sit to stand test. You can see a physical therapist and have them do all these assessments on you. They are fun to get a baseline, and then you work on getting better. On the 5 times sit to stand test, you have the patient cross their arms and you see how quickly they can do. They can sit and stand up and down from a chair, and we have standards on how quick that should happen. And then if it's not quick enough, if the patient is at risk, and the musculature is weak, we have to train them. On the right side, we have the grip strength. And grip strength, gosh, there was so much research done on grip strength, particularly in nursing home. It's such a great indicator, and then we can extrapolate to the rest of the body. It indicates generalized muscle loss when it's weak, leads to weakness, loss of balance, increased falls and fractures. So grip strength is one of the most researched tests that I know of. And it's so easy to do. We have it in our clinic. As soon as the patient enters the door, we do it and we get a baseline, and then we check in our program every 6 weeks. Postural stress, we already discussed it. I wanted to show you how we measure it in clinic. I have this fun technology, and I do a postural analysis. The computer is able to, so we take a picture of the patient front and side, and then the computer starts measuring the postural stress on the skeleton, head position. You know how I was showing you on the mat, on the pictures before, that forward head I'm so interested in, and I'm always working to bring it back and to align this vertically. So this allows me to get these measurements on the patient. You don't have to have fancy technology. It can simply be done with an inclinometer or a plumb line, but I like it. It's fun, and patients like to look at these reports. And then same thing, I keep measuring every 6 weeks until we're satisfied with the patient's progress. Here's a little bit of data on fracture risk and poor recovery because of postural abnormality. Journal of American Geriatric Society, older men and women with hyperkyphotic posture have higher mortality rates. So we know why, right? Because we talked about this, that the collapse of the spine, collapse of the ribs on top of the lungs lowers vital capacities and increases mortality, because we do not have resources to come back from lower vital capacities with a high health event. And a little bit more here from research journal Spine, height loss, right? And you, Shelley, had mentioned about height loss. So how does height loss occur? What it occurs with forward collapse of the spine. And so that was another interesting thing in the Liftmor study, that they measured patients' heights, and they all grew about a centimeter. And we know that that was not real growth. There was just simply increase of vertical alignment because of those beautiful back extensor muscles becoming stronger. Here's another one that I think it should be present in every provider's office, like in your primary care doctor's office. They should ask you to stand on one leg. And this in this study, it's such an incredible predictor for mortalities. You can ask me for the study, and I'll give you the copy. You can predict mortality up to 7 years if a patient is not able to stand on one leg for 10 seconds at least. This is almost like taking blood pressure or heart rate should be part of the standard testing that we're doing for patients. So a single leg stance, predictor for mortality, and of course is a big risk factor for falls. Here's another one. You can go here on humanlocomotion.com. Dr. Tommy Shard has a lot of fun devices to strengthen the foot and toes. And here's the research. A best predictor for falling is toe strength. So in our clinic, we're having so much fun with strengthening the toes. We got these devices here on the left, and every single patient has their own. So I teach them the exercises. They do it at home. It's incredible. It's actually so powerful, even for patients that have neuropathies in the toes, strengthening the toes, the arch, and the ankles. Such an incredible exercise to do. This is a newish research, and I'm excited to bring it to you. Look on his website, humanlocomotion.com. So we went through a lot. We looked at all of these lifestyle factors. We grouped them into three categories, so we make them easier to unpack. And I did my best to present some of the strategies that I thought they were more important, most important. All of these that I use in my clinical practice, and I've seen successful outcomes in my patients. And I want to thank you for your patience. It was a pleasure to present this information to you. And I'm going to stay on for questions.
Oh, that is awesome. This has been one of the most informative talks we have ever had.
Oh, thank you.
So comprehensive. Uh, I I can't tell you. I have learned so much tonight. And I'm so glad so many people were on live to be able to hear you. And I'm sure you'll have even more. There was a lot of questions already, but I just want to thank you because it was so complete. I don't think I've ever seen such a comprehensive talk. Um, I want to start out by saying I'm so impressed how you are just such a learner and someone who just continues to grow and want to know more. And I, I really appreciate that because it's so multifaceted, this issue. And we've been on for 4 years with a new speaker every month. And it blows my mind how much there is in this field. And I
Yes.
feel like I can never get all of it. It's just so much. And, when I had asked you, I thought we were going to just talk about ONERO tonight, even when we first got on together. And of course, I know that is a passion for you. And it should, I feel like rightfully so after having gone through a lot of it for a year myself. Um, but I have to say it's a complex issue and you have
Yes.
addressed so many aspects of it in such a great way. So
And Shelley, it is complex and also it's just so important to be individualized because when that patient is there, then you have to, that's the funnest thing. Then you have to tease it out, what is applying to that patient and giving them the time
yes,
to have that conversation and see where they need to do the work.
yes.
Mm.
There were so many things you brought out that really I haven't heard before. Like, for example, your numbers could be the same in terms of your bone density, but if your muscle strength was much better, your fracture prediction would be much better as well. Um, I missed a couple things. One being, what was Dr. Tom Michaud's website? Can
Yeah, so it's humanlocomotion.com.
okay.
He has a lot of fun stuff for fracture and fall prevention. Absolutely highly recommend him. I get a lot of my resources from him. He's been in the field for a long, long time. Wrote a couple of books on foot orthosis, human locomotion. He really is an expert in the foot and ankle. And I always like to go to people that I know that are so smart and I can learn a lot because I always am looking to complete my patient's care. So we're doing ONERO, but if my patient has weakness in their toe, I need to address that. So whatever my patient has going on, I need to address the entire person. So that's why I'm always looking to see who's there that's really smart, has done a lot of work in areas, and I want to bring it in and yeah, serve my patients.
Is that a device that he sells as well? That foot,
Yeah, that is called TOPRO. And I've been in practice for a long time and I did orthopedic work. I love to rehab the foot and ankle. I feel like not a lot of therapists work in that area. It's just such an important area. It's just stability comes from the ground up. Um, And so I always made my own makeshift devices because there was nothing there that would put these muscles in such a position that you could strengthen them.
Yeah.
And then all of a sudden I see he creates this and I'm all over it. So it's a silly plastic device, but to me it has huge value because of the way that it positions these joints so I can strengthen these small muscles in the foot.
Sure.
It's
And
called Toe Pro.
Toe Pro. Okay. I appreciate that. The other, uh, the, do you in your practice do the biofeedback therapy as well?
We do, yeah. We
Wow.
do. We have a therapist there. We've done it for years. I even got certified in it myself, but I am rusty on it. I just thought it was so fun, even when we trained to put these sensors on, and then the instructors would give us different stressors, and I would see my blood pressure go up, or my heart rate go up, or my skin temperature, or the skin acidity changes. It's
Wow.
incredible to see these markers changes just because he would say something to me, or I would say something to him, and then we would do certain training, right, and then he would elicit the same stimulus, and then I would have to work on a different response, because the
Wow.
idea is, right, that you know stress is the stress response, not the stressor. That's the problem, right? How we react to stress is the problem, because stressors will always be around, but somebody who learns how to mitigate stress has a better stress response. And that's what we're after, right? To lower that stress response, to have better responses, a lower cortisol, despite the fact that we still have stressors in our life.
Yes, for sure. I'm also interested in it sounds to me as though your program, when you go in, your a patient starts with you, they have a lot of resources available to them, in terms of even like getting recommendations on protein consumption, and it's so individualized to their needs. I know there's a lot of online programs. What is your take on that? And how, for someone who doesn't live near an ONERO provider, what would you recommend?
I would say for exercise, definitely target. I made sure that I specifically spoke about these important muscle groups that keep popping up in research as being so important for fracture prevention. Strengthening these postural muscles, and any physical therapist can do that. And they can teach you the basics of strengthening of the back extensors, hip extensors, and postural exercises. So start there. Um, I think that's the way to start. Yeah.
Back and sensors.
But have them assess, right? So you want to have an assessment, so it's specific to you.
Yeah.
Um, and then the same clinician will have to reassess and make sure that that work is having an impact and it's creating a change.
Yes. Um, Also, I just one more other thing I wanted to ask before I'm going to open it up to what the people have asked in the group. I have my own questions. um, but you had mentioned a few people when you first started the talk, um, and I loved that. You had talked about Dr. Brown, um, and was Dr. Brown was the one that talked about how the body is so sensitive to loading. Is that was that the one?
She actually wrote her book Better Bones in the 80s, and nobody was talking about these lifestyle factors for osteoporosis. I believe she was the first one to pioneer this idea, and that's because she's an anthropologist and she studied
Oh,
other cultures.
Dr. Susan Brown.
Yeah,
Yes. Okay. Yeah.
exactly.
Yes. Yes.
And she knows, she understood historically, well, these cultures don't get they don't get fractures. What's going on there?
Yeah.
And I resonate so much with her because I lived in a culture like that, and that didn't make sense to me. Why is this a disease all of a sudden, when it looks like it's all lifestyle driven?
Very true. Isn't it true? Okay, that's great. And then jamesclear.com, James Clear, his he
He
talked
wrote
about.
a book. It's pretty new. It's called Atomic Habits. It's
Hmm.
fun to read. It just goes through some of these routines and daily habits that you can work on that are so impactful. And I always tell my patients, because people believe that you have to make some incredible, radical thing in your life to see change. But the reality is that our daily routines, the little things, that's what adds up. And if you stay focused on those little things and you move towards a goal with them, then all of a sudden at the end of the year, you see something incredible adding up. Or
Sure.
if you just ignore it, you're just going to slip down the slippery slope because the decline will just occur naturally.
Yeah, that's so good. You know, some of our people on in our group are seeking Liftmor, either the Liftmor ONERO program, I mean the ONERO program, excuse me, and or they're working with a physical therapist or strength and conditioning coach right now, in their city, wherever they live. Um, and I think some of them have had questions or comments. Let me just take a look at what some
Sure.
people have said. Um, is there a website that you know of for people that want to seek ONERO type training that is near them?
Yes. So if you go on the Bone Clinic, this is the website for Dr. Belinda Beck's clinic, and they have a map and they show you where the licensed providers are across the world.
Oh, that's great. So theboneclinic.com.
Theboneclinic.com. And so if you, let's say you live in an area and there's not a provider, you can stimulate the conversation with a physical therapist. Go in there and just walk into a practice and have that conversation and say, wow, this is really incredible. It's changing lives. Would you be interested in getting licensed? And start stimulating some conversation around your area. And I would love to see this growing because we do need to do this type of training. And I am very concerned that people will do this on their own, and it's just not appropriate. You need to have the guidance. You need to have the supervision. This just doesn't work on your own. And we work with patients for a year, and we do discharge patients because they do get confident on your own at the end of that year, but you need that year.
Yeah,
Some of them remain on board with us, but a lot of them are confident by the end of the year to work on their own, and we transition them successfully.
that is so good. Okay, let me just ask a couple other questions. So most people are just saying incredible presentation. Um, have you seen improvement in DEXA scans from your own patients?
Yes, yes, we're seeing improvements in the DEXA scans. They are pretty consistent with the data that we're seeing from Australia in in the way that we always see a little bit more improvement in the spine and a little less in the hip. But again, the reason why I keep bringing up that muscle, because my main preoccupation is with fracture, and I need to reduce fracture risk in my patient, even if the DEXA is not able to see certain aspects of the resilience of the bone that is built because of this loading. If you remember, one of the studies that I mentioned there looked at this community in Gambia, and these women, the DEXA scans were horrible. No one was fracturing. And you know that's because DEXA can be blind to certain aspects of bone strength. It's just not it's how how it measures. It just looks at density, but that's not the entire story. And I'll say one more thing, because I did spend time in various clinical settings. You know, I have nursing training and PT training, and I spent time in medical surgical units in the hospital and in nursing home. And I've seen a lot of patients with good density scores that fractured. They had bad fractures and didn't recover. And as you know, the prediction rate for DEXA is not great, is 40%. So you have a test that can only predict 40% is not so great. So having that in mind, I'm not against it. I actually think it should be done way earlier. But I do not like the fact that we're just hanging our heads on one thing when there's so many factors that we really, really need to consider. And then we have patients that are matched with the DEXA scores, and they are only given a single therapy, which could be pharmaceutical, and we're missing all the other factors that play in fracture prevention. And those are the patients that are going to fare out very poorly. And I've seen that in hospital many times. And it's just incredibly concerning for me. And yeah, it's important
So
to look
I
at all
know,
of these factors. Yeah.
I know. We hope it changes. Do you have,
Yeah, well, Shelley, you're initiating change because we're talking about this right now. And this change does occur from bottom up. You know how it is. You have to work with the consumer to make change, and then you have a different demand. It's never going to come from top down because top down is too protocol oriented. Hospital health protocol, hospital has liability. To have something, a study going from research to clinical practice, sometimes it takes 18 years. Well, we don't have time. Um, so we're talking about this right now. And then the patient is starting to be more demanding about these things and not to be pleased with just giving one solution. Really starts understanding that something else has to happen. And so you are initiating this change.
yes, we jump in the United States to the medical model, which usually translates to pharmaceuticals.
Yeah, so we're just matching a test with one drug, and again, it could be warranted in some cases, but everything else has to be the patient. All the risk factors have to be considered if we're going to care for that person.
I know that in the Liftmor, I'm the ONERO program, excuse me, I keep saying Liftmor. ONERO program, there are primarily the 4 exercises that Belinda discusses. The deadlift, the squat. The other 2 escape me. I know that either way, we need to have people monitor us, that these are things we can't increase at home on our own
No,
safely.
absolutely not. And I know that many times patients reach out from, I do various talks and they'll be like, well, can you teach me this online? And absolutely not. This is something that I need to be hands-on with you. I'm sure you realize that I'm just so involved. I'm so hands-on with my patients. I need to see that patient, put my hands on them, see their movement, the quality of their movement, see their deficits. The movement has to meet the person.
Yeah,
You don't, I cannot teach this online, unfortunately. I would love to, because then I would have so many more patients, but I can't. This is just something I have to do hands-on. And
yeah,
this is why you need to start stimulating conversation in your local, where you live, and
yeah.
have, it has to be face-to-face. You have to have a clinician that understands biophysics, understands pathology, understands human movement, and has appreciation for it. And that has to be done face-to-face.
And I think you made an excellent point, Dr. Tamas, when you talked about having at least a physical therapist examine your own
Yeah,
physique and give you an assessment. Would
yeah.
that be your recommendation to start?
Absolutely. I would absolutely start there because that's where we're seeing things going down here with those postural changes. I would like to see people working there much earlier. A lot of the times we're seeing patients, it's so far gone. And I'm like, oh, I wish, you would have started this earlier. But
Yeah,
anyway, it's never too late. But this is good. If you don't have ONERO near you, let's grab those postural muscles and make them strong.
yes. Um, Let me just take one more peek then. We've kept you a long time. I appreciate you so much. This has been so fascinating. Um, I know we have people in Canada that mentioned, but I think you know that you can access ONERO from that bone clinic website.
Yeah, I know. Belinda Beck visited Canada. There are some clinics there, so I don't know where you live, but check out the Bone Clinic's website and go to that map. I will say there's a big interest now from providers too. So these clinics will start popping up. And again, you be the one who go and talk to physical therapists and have them interested in doing this.
Mhm. Um, someone asked two things. One is, would swimming improve the back muscles enough, or would you still recommend weight
Wi-
bearing?
I would do weightlifting. Yes.
Okay.
Exercise with weights that a clinician there will assess you, maybe will start you body weight at first, depending on what your baseline is. And then we'll start slowly adding some load and will progress you as appropriate.
Okay, thank you. And then do you have any opinion about the TBS program, TBS scores that we can get on our DEXA? How do
Yeah,
you get
so the TBS would just add another level of investigation to the bone quality. So it's that's what it's doing there. So I think it should be done every time. It's really not getting done that much. I see it once in a while. My patients, I ask them to request it when they go, so then they get it. So I like to add that level, and some patients are also looking in this new technology, the REMS, and they are getting some testing with that, and that gives you the fragility score there. So that's a newer technology. We don't know so much about it, but I do know that it's coming on strong, and FDA approved it last year.
Great, that's great. One last question, and then
Sure.
thank you. I can't even thank you enough. But if someone had currently a back fracture, uh, would you suggest they wait, or how to proceed in their own strength training?
Yeah, so if you had a back fracture, most likely you already saw an orthopedic doctor. The orthopedic, usually when we're looking at fracture healing, it's about 6 weeks. So the doctor will see you then again and will say, okay, well, that fracture is healed now. And now you go ahead, and it's even more important than ever because we have patients in our clinic, some had 7, 8 fractures already. Now those extensor muscles that I keep showing there in that picture that are keeping you upright, it's even more critical to strengthen them because they will continue then to support the spinal architecture. You want those to be very strong, and you can still load them, but you have to be strong, you have to be upright and supervised.
Yeah, yeah.
And so we absolutely work with patients with fractures. When the fracture's healed, we get the green light and we start working even more so, right? Because we want to prevent further ones. It has to be done correctly and supervised.
I have to say that a year ago, I had been released from PT after having a ski terrible injury, very bad, kind of near the piriformis muscles, and it was from overuse. It wasn't from a fall, and I had sacroiliac joint dysfunction. So, but I was in so much pain. I was on painkillers. So,
Yeah.
by the time I was released from PT, they didn't really, they said you're 80% better, but I could no longer ski or hike or anything.
Mm.
And just telling you my story because I I knew that one of our members, Mary Ellen D, who's on tonight, who's made some very good comments in here, had been going to a gym near me and had been getting very good results. I went back to the doctor and asked for a new PT order. And I was able to go there for 6 months with a PT and start building back my those muscles under
Yeah.
supervision of a PT. And then
Yeah.
they graduated me about 4 months, 5 months ago to regular training for my osteoporosis.
Yeah.
And I do pay for that now. So if that, you know, I don't know if that's a similar scenario as what you're seeing in your own practice, that happens to people that come to you.
If they had fracture or injury,
Do they come then, or do they come after they?
yeah, so we have various programs in our practice. We do a regular physical therapy and rehab. So sometimes they'll come to me to start ONERO. I'll assess them and I'll be like, you know what? I want you to do PT for 6 weeks. and then return. You are not ready for ONERO. I really want you to work on this or on that, or they have pain, or I feel like it's a deficit that they really need to rehab. So absolutely we'll do that. And PT is usually covered by insurance. So we'll send them there. We'll get them rehab, and then they'll come back and we'll get them in ONERO. So we've done that. I've done that multiple times.
Um, Dr. Tamas, do you have some of your information so that people live in New Jersey and can come to your program, they can access your information readily?
Yeah, very easy. You can go online. So natural medicine and rehabilitation, that's our website. And then once you open that, you will see ONERO there. You will see our team. You will find me, and there's going to be a place where you can ask for an appointment. And so then we'll reach out to you if you do reach out first.
I spoke Somerset, New Hampshire, but I meant
New
Somerset, New
Jersey.
Jersey.
Yeah. So
Sorry.
natural medicine and rehabilitation, that's our practice. Very easy to find. ONERO is right there at the top. And so it's easy to navigate.
That's great. Thank you so much.